to do, so open with, let me do slide. Okay. This is making it smaller. Okay. I'm trying to open it without, so I. One minute, okay? I'm having a little issue here. Share. Can you see now?
No, for the moment I see only your photo.
Oh, okay, wait. So, now you can see the full screen?
Yes.
Yes? Okay. So we are going to do respiratory system. So if you know the anatomy of the respiratory system is that we have the sinuses, which are these inside the bone, we have the sinus, right? The spaces, this is called sinuses. We have the nose, then we have the nasopharynx, then we have the pharynx, then we have larynx, then down here this tube is the trachea, then this is the bronchus, right? Then the two branches of the bronchus, right bronchus and left bronchus, and then we have the bronchioles, which are the small little, this branches are called the bronchioles, and then we have, what is this, like balloons? This is your lungs.
Do you know? I don't see. I see only day 2. I don't see the picture.
You don't?
No.
Oh. You don't see this, huh?
No, I don't see the picture.
We are not seeing this slideshow.
Now I see it. Yes, alveoli, bronchial, larynx, sinuses.
Okay, wait. So if I go down now, you're seeing it?
Yes, now I see it. Review of anatomy.
Yeah, so you know the anatomy, right?
Yes.
So we have the sinus, the nose, the nasopharynx, the pharynx, the larynx, then the trachea, then the bronchus, the right bronchus and the left bronchus. The right, then we have the two lungs. The lungs, in this one, the right one, we have 3 lobes. 1, 2, 3. Upper lobe, middle lobe, and lower lobe. And in the left one, we have two lobes, upper and lower. Okay? And this is the alveoli. That's the smallest part, which is like the balloon. This is the alveoli. This is our anatomy of the lungs, of our respiratory system, right? Now, physiology, how does the mechanism of breathing happen? So, human anatomy, physiology, air is circulation happening in the atmospheric air around us, right?
Yes.
It will go through our nose into the nose, and then the trachea, the lungs, it will go and go to the alveoli. In the alveoli, what happens? Gas exchange will take place, and carbon dioxide will get outside of the lungs into this air, and then venous blood will carry the oxygen in the and then it will oxygenate, and the arterial blood here this exchange happens in the membranes of the alveoli. And then what will happen? Carbon dioxide from the tissue will come out into the venous blood, and then oxygen will go into the arterial blood, and the oxygen
Blood.
will go deliver in the tissues, and the venous blood, the carbon dioxide will get released here, and then it through the, when you exhale, it comes out.
Mhm.
This is how it the respiration happens. Where does the respiration? What tells the body to breathe?
We are breathing with the oxygen.
No, where? What controls it?
It's controlled by the bound by the centers in the brain, in the
Brain,
part
yes.
of the brain.
Yes, in the brain, the respiratory center in the brain will tell to start the breathing out. First exhalation, and then carbon dioxide level goes up. Then it senses in the brain, okay, the carbon dioxide level is too much now. Then it will tell exhale now, and then exhale out the carbon dioxide, and then inhalation will happen automatically. Okay?
Yes.
So the gas. So this is the explanation about that. So gases like in the alveoli, how it happens is coming from here. What it goes into the hemoglobin in the red
Hemoglobin.
blood cells will become, it will absorb the oxygen, become oxyhemoglobin,
Mhm.
which is red in color. That's why your arterial blood is more red in color. And that will become arterial blood, and through the arterial blood, we need to know are these sounds, crackles.
Crackles.
Crackles means like
Uh-huh.
something like that, crackles. That is, when you hear crackles, mostly it is because there is fluid in the lungs. In pulmonary edema,
Mhm.
there is fluid in the lungs, and that time when you listen to the someone with pulmonary edema, they will have pink frothy sputum coming out from the mouth, but when you listen to their lungs, crackles is what you will hear.
Mhm.
Okay. Then bronchi is that that kind of sound, as if there is secretion moving. Phlegm is moving in the respiratory tract. That means it is bronchi.
Mhm.
Okay, and bronchi can be seen more. In which cases do you think we'll have bronchi when there is phlegm?
In case of coronavirus
Infection,
infection,
any infection, pneummonia because of
pneumonia,
coronavirus,
yes.
because of any bacterial pneumonia or viral pneumonia, or any of those things. When they have pneumonia, that is what we hear, bronchi. Wheezing is like as if there is air is struggling to come out, like that kind of sound.
Mhm.
Okay, that is happening when the tubes become narrow,
Mhm.
when the bronchus becomes narrow. So when does it become narrow? In what condition?
Uh, During the condition of the um, microbes.
No, microbes, usually it is bronchi. If there is bronchitis or something, wheezing is normally in asthma or COPD.
Mhm.
That time there is wheezing because the tube become narrow.
Mhm.
You understand?
Yes.
The bronchial tube will be narrow, and the air is trying to escape out from the inside to the outside. That's why it is making the wheezing sound. That is, in asthma, it is typically wheezing. Okay.
Wheezing
Then
asthma. Mhm.
wheezing sound, yes. And friction rub is when there is something called as pleurisy, or like when the two membranes of the pleura are rubbing against each other, then
Mhm.
you can hear a rubbing sound, and that's the friction rub.
Mhm.
Okay. Now, what are the procedures related to the respiratory system? The procedures that normally, I mean, some of them are abdominal thrust. When they use abdominal thrust, what is this procedure? Do you know?
No.
No, this is when someone is eating or something, they choke, and when they choke, you hold the abdomen and you go up like that. and that to dislodge the food that is in the throat.
Mm-hmm.
That is the abdominal thrust. You know, Heimlich maneuver.
Heimlich, yes, a massage. Yes.
Yeah, Heimlich maneuver. Same. It's called as abdominal thrust. It's not
Okay.
massage. Massage is cardiac massage. That is
Uh-huh.
different. CPR. But this one is to dislodge the food that is stuck in the throat,
Mm-hmm.
and that's called abdominal thrust.
Okay.
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 Then bronchoscopy means what? What is bronchoscopy?
Scopy. It's checking inside the bronchos with the
Yes,
scope.
with
With
the
the
scope. Very good. So bronchoscopy. Then chest physiotherapy means you are using your some instrument or your hands to dislodge the secretion or anything that is stuck. That is called as chest physiotherapy. Okay.
mhm.
And then chest tube. You know what chest tubes are?
The tube that is inserted inside the chest, inside the lungs.
Yes, inside the lungs, so that to remove either the air or fluid or
Fluids.
blood or anything
Mhm.
that is there inside the chest, it's not supposed to be there. So to remove that, they put underwater seal drainage, and that's called chest tube. Okay. Then we know,
Inspiration.
yeah. Then we know about mechanical ventilation. You know that you use a ventilator. You put the endotracheal tube inside the patient, and then you give breath from the machine to the patient. That's called mechanical ventilation.
Ventilation.
Okay.
Mhm.
Then about oxygen therapy. This is also related procedure. Anytime the person is having difficulty breathing, when the saturation is down, we give them oxygen.
Yes.
Then the other procedure is suctioning the airway. When there is sometimes the patients are unconscious or they are too weak or something and they cannot cough out their secretions and spit out. So then we have to put a catheter and we have to suction,
Mm-hmm.
right?
Suction.
That's
Yes.
called suctioning, which is a very common thing that you will do in respiratory floors. Then tracheostomy care. For some people who have some problem breathing normally, they make a hole in the trachea
Yes.
and then they breathe through that. So that is when we have to take care of that. There's a procedure how we take care of
Mm-hmm.
it, right? So that is called tracheostomy care. And then thoracentesis. This is done by the doctor, and this is insert a needle and remove the fluid, pleural tap or thoracentesis it's called. And we, our job as a nurse is to assist with the procedure, to explain to the patient, to give sedation before the procedure, and all these things. Okay, so these are the related procedures related to the respiratory system. Now the different kinds of pathogens. Pathogens means patho means disease, gen means something that make the disease. So pathogens are those that make diseases in the pulmonary system or respiratory system, and that is bacterial. The different types of bacteria that can affect the respiratory system is Bordetella pertussis, Streptococcus, pneumoniae, Haemophilus influenza, Klebsiella pneumoniae, Mycobacterium tuberculosis, Pseudomonas aeruginosa, and there are many more like COVID, coronavirus, so many others, right?
Mm-hmm.
Then we have adenovirus, retrovirus, HIV, then fungal infections like histoplasma, and then protozoan infections like pneumocystis carinii. So these are the different kinds of microbes that are going to affect the lungs.
Lungs.
Okay. Related pharmacology, you normally the drugs that we use in respiratory system is oxygen. That's the most common one. Then bronchodilators, and that is for asthma and for COPD. And then when there is thick secretions, you use mucolytics and expectorants, which will loosen the secretion and help to
Uh,
cough up and bring it out. Antitussive is like anti-cough, like if you have dry cough, then you use antitussive. Then narcotic antagonists, like sometimes you give too much morphine or too much some narcotic and the patient doesn't breathe, then you have to give something like naloxone or nalorphine to make them awake again to start breathing. So normal narcotic antagonists also we are giving in these floors, and then antihistamines. These are also related to, like if there is any sudden anaphylactic reaction, then what we do, what will happen is the airway will become all swollen and will be closed, right?
mm-hmm.
So they cannot breathe and they can die because of the anaphylactic shock. So at that time, we give them antihistamines, or sometimes we give them steroids so that the inflammation is reduced and then they have more room to breathe. So what are the different disorders in the respiratory system? You can have pulmonary embolism or pulmonary infarction, then pulmonary edema, pneumonia, pulmonary tuberculosis, COPD, pneumothorax or chest injury, or you can have different types of carcinomas or like laryngeal carcinoma, bronchogenic carcinoma, lung cancer, or you can have adult respiratory distress syndrome and also carbon monoxide poisoning. These are some of the diseases of the respiratory system. Now, this is basically just an overview of the respiratory system that we just did. Now we are going to go into practice questions. Okay. Okay. So read the question.
Okay. A client is admitted to the medical department due to pneumonia associated with influenza. Which of the following interventions promotes airway patency? CATA. More
No,
answers.
SATA. What does that mean? SATA. Select all that apply. Means?
More answers.
Yes, more than one answer will be there. Yes. So what is the stem of this question? What is the question asking you? Remember yesterday we said rephrase the question and understand what the stem is. So what is the stem? The patient has pneumonia.
Pneumonia with influenza.
So now what is the stem of the question is this: promoting airway patency.
Yes.
Right?
How?
Yeah. So how we can promote? So which are the things that help with airway patency?
Increase fluid intake. Frequent turning. Apply chest physiotherapy. Schedule actives after treatment. Provide a quiet environment. Teach client to avoid stress. Stress. As for me, the stress is not important.
Okay.
Increase fluid intake. Yes, it's good. So
every time, so this is what I want you to do. Every time you have a select all that apply, you put on one side right answer and wrong answer, or good answer, bad answer. Okay, two columns, and then you put which are the good one, which in one side, which are the bad ones in one side. Then I look at the question one more time and say, okay, what promotes patency? Then they are asking for, then you choose which ones they are. Okay.
Yes.
Okay, so now the good ones are which one?
Increase fluid intake after apply chest physiotherapy. Schedule activities after treatment.
That's a good one or a bad one?
This is neutral.
Neutral. What about frequent turning?
Yes, it can help, especially if the person is staying in this position. So.
What about quiet environment? Will it help with airway patency?
No, quiet environment. No. So frequent turning, yes, can help. Chest physiotherapy and increase fluid intake.
So A, B, and C?
Yes.
So yes, increase frequent apply chest. So increasing fluid intake will facilitate easy expectoration of mucus. Frequent turning will promote client with altered level of consciousness. You know, in your nursing home, you're seeing such patients, right? You're turning them every 2 hours.
Yes.
Right? Should be placed in sideline position to prevent aspiration. Applying chest physiotherapy is an aggressive measure to maintain airway patency and may be required by certain conditions. This usually requires doctor's order. The other answers are not for airway patency.
Yes.
Yes.
Not important.
Next one.
Yes. A patient with COPD is receiving discharge instructions from the nurse. The nurse should include which of the following to be avoided by the patient. Uh, Choose more.
Select all that apply.
Yes. So, what is COPD? I'm thinking uh,
Chronic
chronic
obstructive pulmonary disease. Write it down. Chronic obstructive pulmonary disease.
pulmonary disease. Perfect. So the person is uh, has it for a long time. So
Mm-hmm.
mm,
Long time.
yes,
Yes. From many years, like 20, 10 years, 15, 20 years. They'll be smoking, or they will be not having, maybe they are having asthma, and for a long time, and then it becomes chronic, and then it becomes COPD.
mhm. So the nurse should include which of the following to be avoided by the patient. Uh, so uh, I'm trying to understand what this mean.
Mhm.
Uh,
So rephrase it in Italian, and then ask what they are asking, and then you read the question and put them in the two sections, good ones and bad ones.
uh,
Oops, did I change something? Okay.
uh, so the nurse must understand what is the problem, what is the um, motive, the cause of the problem of the patient. Uh, and the nurse is trying to understand
So
the
the nurses here, the nurse is telling now the patient is having was admitted with COPD, and now he's okay and he's going home.
Mhm,
He's receiving discharge instruction.
mhm,
So the nurse should include which of the following to be avoided by the patient.
mhm. Um, so
Which the patient. So now the patient should avoid one, two, three, whatever, to prevent again COPD. Because see, once the patient has COPD, like chronic obstructive pulmonary, it's not going to go away. It's going to be there. Patient will have that all the time.
repeated.
But patient gets admitted only when there is exacerbation, when the condition becomes worse. They have breathing difficulty, or they have like COPD exacerbation, or they have pneumonia along with it, or they have CHF. Some people have congestive heart failure also along with COPD. And when that exacerbation happens, they get admitted. Once you treat them with whatever is needed, like you give them steroids, you give them high oxygen flow, and you give them antibiotics if they have pneumonia, or you give them Lasix if they have congestive heart failure, and then you treat them, and then you send them home. If they don't take care, again they're going to come back to you,
Mhm, mhm.
right? So, what triggers the COPD? Those things the patient should avoid, isn't it?
Cold air, cigarette smoke, um, uh, mm, and influenza vaccine. I don't know.
Avoid,
And
avoid. So now put what are the good things and the bad things in two columns. Cold air, is it good or bad?
it's bad for him.
So put in the bad column. Cigarette smoke, good or bad?
Uh, this is bad, bad,
Put in the bad column. Exercise, good or bad?
positive.
So put in the good column. Cleaning products. Cleaning products. What can happen with cleaning products?
Uh,
Sometimes these patients who are having COPD or asthma, remember how asthma triggers because of some allergy, right?
exactly.
So when they have allergy to cat hair, carpet, or maybe incense stick, or maybe perfume, they will have allergy, and the allergy can trigger asthma, which can trigger COPD.
Mm-hmm.
So sometimes even cleaning products are, they have to be, they cannot smell clothes. They have to better wear a mask.
Mm-hmm.
So it's a good thing or a bad thing?
Negative,
Yeah, to put in the bad column.
bad column.
Stairs. Yeah,
Po-
stairs. Stairs is good
positive,
or bad?
positive, good.
Doesn't matter, right? Yeah, it is neutral. Children,
It's neutral.
neutral. Okay. Influenza vaccine is good or bad?
Influenza is a good, good.
Good. You have to take the vaccine. So, which are the ones that are bad in this? In your bad column, what all did you put?
Cold air, cigarette smoke, cleaning products
Products.
only.
Okay. So now you read the question again. The nurse should include which of the following to be avoided. So the bad things the patient should avoid, which means these, right?
Yes.
Now let's check the answer. Yes, you are correct. So cold air, cigarette smoke, and cleaning products. Fumes from chemicals,
A cigarette.
cigarette smoke, and cold air can irritate the respiratory tract and cause exacerbation. Exacerbation means flare up.
Mhm.
You understand what's flare up, right?
Yes, yes.
Becoming too much. So the exercise and stairs should not be avoided unless they cause intense strain, which they didn't mention in the question whether the patient has intense strain. So we didn't choose this. People do not need to be avoided unless they have respiratory infection. So no need to avoid children. Maintaining current vaccination helps to prevent exacerbation. Patients with COPD should receive an influenza vaccination annually and pneumonia vaccination when indicated. Okay, so everybody in the United States after the age of 65, they give them this pneumonia vaccine, I think every 5 years, and influenza vaccine is every year we have to take. Every year during flu season, I think October is the time we have everybody takes, including us, like healthcare workers. We all have to take, right? You're taking, right? Influenza vaccine, flu vaccine.
For the moment, no.
Why?
Uh,
Yeah,
be,
now you
be, be,
work with it.
yeah, so we have the tests. Every day we have the tests for the COVID. So when we are entering, we have the test for the nose.
No, not only COVID. This is not for COVID.
Uh-huh.
This is for influenza, flu.
Mm-hmm, mm-hmm.
But
No.
in the hospital, if you are not having flu vaccine, they will not let you work. I think
Uh,
nursing home is lenient, but in hospital they don't allow you to work
mm-hmm,
without the vaccine. Even for me, I'm sitting at home and working. Still, I have to take the vaccine.
mm-hmm, mm-hmm. I had it last year,
Yeah.
maybe 7 year 7 month ago. So maybe it's
Yeah, yeah. So now
functioning
you
too.
next year you will this year October will be the next dose.
Mm-hmm,
Okay. Next question.
mm-hmm.
Read.
The nurse is performing a physical assessment on a patient with COPD. Which of the following signs and symptoms should the nurse expect to find? Select all applicable.
Mm-hmm.
Uh, so the nurse is checking.
So we are checking about the signs and symptoms. So now make two columns. Which
Mhm.
is the signs and symptom? Is fever a sign? Yes and no column, right? Yes and no column. Fever is a symptom for COPD?
No.
No. Fever will be in pneumonia, but not in COPD. So put in the no column.
Negative. Negative column. Clamped fingers.
Yes, clubbed fingers. Is this
Club.
possible?
No.
Yes.
Oh.
Okay. Now let me explain why patients with COPD will have clubbed fingers. So whenever there is less oxygen in
Mhm.
the body tends to take all this oxygen and give to central organs, which is our heart, lungs, brain, kidney. Okay.
Mhm.
And the peripheral circulation, which is our hands and legs, it will try to give it less blood and more blood to the central organs. So when the fingers are getting less blood, what happens to the fingers is fingers will try to grow
Blue.
more vascular, more capillaries so that it can get more blood.
Mhm.
So as a result, the fingers will become clubbed, like very flat. This is what happens with people who are working, who are living in high altitude. People live in the mountains, right? People
Yes.
who live in the mountains, they don't have enough oxygen there. You know that, right?
Yes. Yes.
because of high altitude, the oxygen level is low. So they have to adapt to live there. So if you look at them, their fingers are all clubbed
Mm-hmm.
because over time the body adapts like this. So same thing happens for the COPD patient also. For long time, they will have less and less oxygen because their airway has become very narrow because of the long-standing disease, and so their fingers will be clubbed. Okay,
Mm-hmm.
yeah. So it is in the yes column.
Yes, colon. Yes.
Yeah, and
Uh,
then barrel chest.
barrel chest.
Barrel chest means like a barrel, like a tub. Is this correct for COPD?
No.
Yes,
Oh.
yes. So so which means you don't know anything about COPD, Bogdan. You need to study. You
Mm-hmm.
need to study about this topic. Okay, because this is one of the very very important topics in US. 99% of the people who come to the hospital to get admitted with lung condition is either COPD, pneumonia, or asthma.
Mm-hmm.
Usually it is any of these three conditions. So it's very common. So you have to know about this. So barrel chest is also the same procedure what I told you. For a long time they don't have enough oxygen. Their tubes are very narrow. So they pull air inside. They do, and they pull the air inside. Okay.
Mm-hmm.
But the tube is narrow, so the air is not coming out. So the air stays in the chest for a long time.
Uh-huh.
So their chest becomes like a barrel. You understand?
Okay. Yes.
So barrel chest. So in COPD, when you read your textbook, you will know there are two types of COPD people. They're called as pink puffers and blue bloaters. You will see this, okay?
Mm-hmm.
So that both of these are looking like a drum. Their chest looks like a drum. So that's why they're barrel chest, okay?
Okay.
Yeah, so it is in the yes column. Then next one.
Dyspnea on exertion.
Yeah, means
Dyspnea.
what?
Yes. This one. Yes.
Yeah, dyspnea means difficulty in breathing
In
on
breathing.
exertion. Yes, they'll have difficulty breathing.
Mhm.
Okay, next one. Shortened expiratory phase means what?
The person is breathing more shortly, more frequently.
No, 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 not frequently. Shortened expiratory. So when in a breathing cycle we have inspiration and expiration, right?
Yes.
So in shortened expiratory phase means like this. Inspiratory phase is long, like this. Expiration is like that. They breathe or they breathe like that.
Mhm.
How do they breathe? Is their expiration long or inspiration long? Which one?
Uh, the inspiration is long and the expiration is short.
Okay, so we will see. Okay, decrease respiratory rate is in the yes or no column.
Um,
Are you breathing less? Rest rate?
uh, uh, I don't know. Yes, yes. As for me, yes.
Okay, let's see the answers.
Because the person is trying to intake to take more oxygen. Mm.
Okay.
Clapped
Okay, so the
fingers.
answer is clubbed fingers, which we said, right? You
Mm.
understood why they
Yes,
have
yes,
clubbed fingers? I explained. You
yes, yes, yes,
understood?
yes, yes,
Barrel chest, I explained. You understood why
yes.
barrel chest?
Because the oxygen is accumulating inside the lungs.
Oxygen, more actually carbon dioxide, not oxygen.
Uh-huh. Okay.
Carbon dioxide because they can't breathe out. They cannot breathe out.
Perfect.
They
Mhm.
breathe in, but breathing out, they cannot breathe out because the tube is narrow.
Okay.
Okay. So COPD is a pattern of chronic airway obstruction and chronic inflammatory response that is often preventable and usually progressive, which means slowly it gets worse for them. Okay.
Mhm.
So signs and symptoms are clubbed fingers and toes, dyspnea on exertion, which you explained, which I yes, when little bit they have to walk, they start getting difficulty breathing, barrel chest, and increased respiratory rate because they can't. throughout the carbon dioxide, they start breathing faster. So their respiratory rate is increased
Yes.
and prolonged expiratory phase. So which means they are trying, always remember, they are collecting carbon dioxide inside. So they want to throw it out. So they are trying their best to throw it out. So their expiration is long.
Mm-hmm.
You understand?
Yes.
So,
Yes.
and then they're trying hard to breathe out.
Perfect.
Okay.
Yes.
So, and they have long, not short expiratory phase. They have long expiratory phase.
Mm-hmm.
And then, of course, we said fever is not associated because in COPD, only if there is infection along with COPD, which means pneumonia is there, then there is fever. Otherwise, there is no fever. Okay. Next one, read
Mm-hmm.
this.
The physician is planning to wean a patient off a ventilator and asks the nurse for which of the following data important for assessing the patient's ventilatory status.
Mhm.
Uh, uh,
So
the,
you know what a ventilator is, right? The machine that breathes
yes.
for the patient.
Mm-hmm.
The patient gets connected to that.
Yes.
They put a tube in the trachea and then they connect to the ventilator, right? Now, weaning from the ventilator means so when we put the patient on ventilator, when we want to remove the patient from ventilator, we cannot just pull out the tube
Mm-hmm.
because it can be very dangerous. Maybe the patient will die. We don't know. So we have to wean. Wean means what?
Means to detach the child from the uh, mother mother's
Yes.
memory.
So it is weaning means gradually
Mhm.
letting the child stop breastfeeding and then going into drinking other milk and eating other solid food. That's called weaning a
Mhm.
baby. The same thing is for a weaning from the ventilator for a patient because the patient gets used to the ventilator.
Mhm.
Suddenly, if you remove the patient from the ventilator, the patient can go into tachycardia, again breathing difficulty. Then you might have to re-intubate the patient.
Mhm.
So to prevent that, we have to gradually take the patient off the ventilator. That's called as weaning.
Mhm.
Okay, weaning the patient from the ventilator. So the doctor is planning that to wean the patient from the ventilator, and so he's asking the nurse for which one of the ventilatory status. Okay,
Mhm.
so what are the things that, in other words, what are the criteria for a person to be weaned from the ventilator? What is the criteria? Is what they are asking
Uh,
us. Yeah.
uh, echocardiogram, yes.
Echocardiogram, why?
Um, oh, no, 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 no. It's not important. Uh,
What is echocardiogram?
the echocardiogram is the sounds.
Of
Uh,
the heart, right? Echocardiogram is like they do a test to see the blood flow of the ventricles and all that. That is what is. So, since this is respiratory system, we really don't do echocardiogram. Yes, heart rate is important. The patient should not be tachycardic, I understand. But echocardiogram, really no need to do. Before weaning, we don't need an echocardiogram.
mhm. Okay.
Okay?
Level of
So now you put, always select all that apply. You put yes and no column,
mhm.
right?
Yes, yes.
So 1 second, I'm having a call. Okay, I'll just
Mhm.
take the call. You by the time you think about these answers. Hello? Hi. Yeah, yeah. Yeah. ഞാൻ ക്ലാസ്സിലാണ് ക്ലാസ് പഠിപ്പിക്കുക പറ എന്തുവാ ഇല്ല ഇല്ല ഡോക്യുമെന്റേഷൻ ഇല്ല ക്ലാസ് പഠിപ്പിക്കാറുണ്ട് യാ അത് ഓൺലൈനാ ക്ലാസ് fees $1,500 for 2 months, and that's 3 hours in it, twice a week class. പേപ്പർ വർക്ക് അവർക്ക് ഗൈഡൻസ് കൊടുക്കാൻ അവരോട് തന്നെയാണ് ചെയ്യേണ്ടത് Mm-hmm. Mm-hmm. If they are അവര് സ്വന്തമായിട്ട് പഠിക്കണം. This is സ്വന്തമായിട്ട് they have to commit to study, otherwise they will not. പാസ് ആവും. Yeah, പാസ് ആവാറുണ്ട്. Yeah. ഇല്ല, എനിക്കറിയത്തില്ല. Okay, thank you, bye. Sorry.
Oh, that's okay.
Yeah. So so we don't need the echocardiogram. What about level of consciousness?
Yes,
We
it's
need.
it's important
Why?
because if the patient is in coma, uh, maybe no, it's not important.
No, it is important. You're correct. Because when we are weaning the patient, we have to ask the patient to be able to take instructions from us, like take a deep breath, hold the breath, breathe slowly. If they are if they are conscious, they are cooperative with us, and the weaning is easy. If it's a totally unconscious patient, it may be more difficult for us to wean. It is possible to wean them and take them out from the ventilator, but the process is longer. Okay, so level of consciousness is important.
Important.
Yes. Then oxygen requirement of the patient.
Uh, yes.
Yes, because if I'm putting a patient on the ventilator and patient is on 80% of FiO2, which is oxygen is 80%, can I remove the patient out from the ventilator? No. If the patient is on 40, I still cannot remove. If the patient is like 30 or like less than 30, then it's okay, because do you know how much of room air, how much oxygen is there in the room air? How many percentage?
Not a lot.
How much?
Maybe 20.
21.
21.
There is in room air, the air that you and me are sitting in the room and breathing, that has 21% oxygen. So if the patient, if it is less than 30 on the ventilator that the patient needs, minimum 30. More than 30 is not a good time to wean the patient. If less than 30, we can remove the patient and put some other oxygen, like maybe a mask or something. Okay, but if it's more than 30, it's not a good time to wean. So we should know how much oxygen requirement is there for the patient at that time. Then only we can think whether we should be able to wean or not. Okay, so this is yes, right? Now white blood cell count, does it matter?
No.
Not really, because it's okay. Maybe this patient's white blood is still high because a lot of other infections going on, right? If we wait for the white blood cell to keep coming down, maybe the patient will be on ventilator for a long time. So that's not important. What about ABGs?
Yes, it's important.
Yes, ABGs is important because if the patient is doing well with 30% oxygen or 28% oxygen, the patient's pH is good, the PCO2 and the PO2 and the bicarb and everything is stable, then it's time to remove the patient from ventilator. There is no need for the patient for ventilator. So that's how we determine. Along with this, if there is tachycardia or tachypnea on the ventilator, those are not, like if the patient is not stable hemodynamically, then we don't wean. Also, if the BP is too high or too low, we don't wean the patient, because we should fix those problems first. Otherwise, what will happen after we remove the ventilator? Again, the patient will go into upside down. Everything will go upside down. Again, we'll end up putting the patient back on the ventilator. Which is, the more the time you do that, the more time is like more injurious to the patient, as well as waste of resources for the hospital, and you will be busy unnecessarily, right?
Yes.
Yeah. So let's check the answers.
Level of consciousness, oxygen requirement of the patient, arterial blood gas.
Yes. So now we are convinced with the answers.
ABG levels, should be assessed prior to any ventilation change to establish a baseline.
Yeah. So
ABG.
every time the patient is on the ventilator, if they're not long term, like in the long term in nursing homes, sometimes in long term acute care nursing homes, they're on long time for ventilator. Those patients we don't do ABG every day, but acute time during hospitalization, acute time, you have to do ABG every day for patients who are on the ventilator. Okay.
Mhm.
Yeah.
ABG levels are often uh, ordered 1 hour after the change to assess for improvement. Patients often are sedated while they are on a mechanical ventilator and need to be alert enough to maintain their airway before weaning.
Yeah. So just as I explained, they should not be sedated. They should be fully awake, and their level of consciousness should be good, so that they can cooperate with us, and we can be. It will be helpful to wean them easily.
Mhm,
Okay.
mhm. Yes.
Yes, and oxygen needs is important to determine. Echocardiogram, as we said, is not going to help.
Mhm,
Also, WBC is not going to help. Okay, next one.
mhm. The nurse is caring for a patient suspected of having a pulmonary embolism. The patient complains of chest pain and a low grade fever. Which of the following signs and symptoms would support this diagnosis?
Okay, so pulmonary embolism. So now from COPD, we came into a new topic. This is pulmonary embolism. Do you know what pulmonary embolism means?
Embolism, it's the substances inside the blood,
Yeah, no, it's a clot.
the clot. Uh-huh.
Clot. Okay, it's a clot, and now here it's pulmonary, which means it's sitting in the lung, blood vessel in the lung, either a
Mhm,
pulmonary vein or pulmonary artery,
mhm.
which is the main artery. So it's a huge deal, right? The
Yes.
patient can die from this. So pulmonary artery is a clot that is in one of the branches of the, either in the main pulmonary artery or vein, or in the segment or in the branches of the pulmonary
Mhm,
artery or vein.
mhm.
So they will complain of chest pain. Yeah, that is
Yes.
that's they will have chest pain with pulmonary embolism. And also chest pain and low grade fever. Low grade fever because of the
Inflammation.
yeah, because of this not really infection there, but because of the inflammation that's happening because of the increase that
Pressure.
in the, yeah, in the pressure. Yeah, so that's why they'll have that low grade fever. So which of the following signs and would support this diagnosis? So along with low grade fever and chest pain, what other thing will be there in
Uh, uh,
PE?
yes.
PE or pulmonary embolism.
Headache, because the person can't breathe normally. Uh,
Headache. Mm-hmm.
Low
Then
oxygen. Tachycardia. Tachycardia.
tachycardia.
Yes, yes. Also, because the body is, the heart is trying to put more oxygen inside the body.
Mm-hmm.
Thick sputum. Uh, no.
Mm-hmm.
Mm,
Okay.
bradycardia, no. Blood
Mm-hmm.
um, tinged sputum.
Blood tinged. Okay, blood tinged. Tinged
Tinged.
means like a blood color, little bit like slight blood color sputum.
Mhm. Uh, yes, yes.
Yes, yes.
And
And then
shortness of breath. Uh, no.
yes.
Ah, yes.
See, someone who is having pulmonary embolism means that the lung is not, like there's no, like blood flow to the lungs is diminished, so they will be trying hard to breathe. No.
Yes. So it's the same situation such like in the COPD. shortness.
COPD, the problem is in the tube of the bronchus, but here it is in the blood vessel.
Perfect. So shortness of breath. Mhm.
So now
Yeah.
headache. Will the patient have headache?
Mhm.
No.
No.
Tachycardia will be there, blood in the blood tints and shortness of breath. No headache, no thick sputum.
No.
Yeah. So, oh, where did I lost it or what? Okay, so signs and symptoms of PE include shortness of breath, pleuritic chest pain, which they put in the question already, low grade fever, blood tinged sputum, and tachycardia. The onset of symptom is usually sudden and intense. Bradycardia, thick sputum, and headache are not associated with pulmonary emboli. Okay,
Yes.
so headache is not there. So, what made you think of headache again?
I thought that the headache is caused by the absence of the normal level of the oxygen, and
Okay, no, normal level. If a with a hypoxia, we don't have headache all the time.
okay.
We don't have, yeah. Okay, next one.
A 49-year-old male patient is in a coma and is supported by mechanical ventilator. Regular oral care is provided by the nurse to this unconscious patient because
Mm. So, is this a select all that apply?
no, only
No.
one
So
answer.
only four answers. So only one is correct. Okay.
Mhm,
Yeah. Please.
answer. Yes, oral care reduces the risk of aspiration. Uh, no. Oral care reduces the risk of aspiration. Uh,
Is
also,
correct or
it
wrong?
can be correct. Yes, it can be correct.
Okay. Next one.
Yes, the patient is fully dependent on the nurse's actions. Uh, in coma, yes. Also. The unconscious patient has a limited ability to perform self care. Also, it's real. Mm. Routine oral care may reduce the risk of ventilator associated pneumonia.
Wow. Okay. What is the question asking you? A 49-year-old male patient is in coma and supported by mechanical ventilator. So on a ventilator, when a patient is on the ventilator,
Mhm.
how often are we giving mouth care? Do you know?
Uh, After a couple of hours,
Every 2 hours.
uh,
Every two
two
hours, we have
hours,
to give mouth care. It's a standard procedure for all patients who are mechanically ventilated because
because
routine oral care will reduce the risk of VAP.
of the saliva. If there will be the saliva.
There is something called as ventilator associated pneumonia. People who
Mm-hmm.
are on long term on the ventilation will get pneumonia because this is a foreign body sitting inside, right? The
Yes.
tube. There's a foreign body. So to prevent that, and when all the secretions are pooling and sitting like this, the chances are that the patient can have that trickle down into their lungs and they can have pneumonia.
Mm-hmm. Mm-hmm.
So when you're doing oral care, you brush and then you suction, no? When you
Yeah.
suction, you remove out everything. So if every 2 hours we go and we clean the mouth and we suction out the extra fluid, we are preventing it from going into the lungs, isn't it?
Yes.
So which is the best answer of all this?
The best. The last one. Routine
The
oral
last
care.
one.
Yes.
Yes, the last one. So that's why the regular oral care is provided by the nurse to this unconscious patient because routine oral care will reduce the risk, not because it will cause risk of aspiration or not because the patient is why the question. This is the stem of the question. I keep telling you, focus, rephrase in your mind and ask yourself, what is the question asking me? All these statements are correct.
Yes.
Yes. But what is the question asking me? The question is asking me, the nurse is doing this because
Mhm.
the best one among this
Perfect.
is this. Is
Mhm.
it? Yeah.
Yes.
Okay.
Mhm.
So routine oral care will prevent VAP. The most significant risk for pneumonia related to being hospitalized is on being mechanical ventilator. So the mouth is fertile ground for bacterial growth. Bacteria from the mouth can go into the lungs, causing pneumonia. So although evidence is lacking to link oral care to the VAP, but this is the standard of care that is followed in all the hospitals. So
Mhm.
oral hygiene and oral suctioning may be associated with 40%. According to research, they say 40% reduction
Mhm.
in VAP conditions if you do regular mouth care for patients on ventilator. Okay, oral
Mhm.
care does not reduce the risk of aspiration. Even if you give oral care or you don't give oral care, if the patient vomits, they will aspirate. There is no, like, oral care will not prevent it. But we are doing the oral care mainly to prevent VAP.
Okay.
Okay,
Mhm.
the next one.
The nurse is caring for a patient dependent on a mechanical ventilator. In order to reduce the risk of developing pneumonia, the nurse should do which of the following? Choose more answers. Keep the head of the bed about 30 degrees.
Mhm.
Administer prophylactic antibiotics. Restrict fluids. Reposition the patient every 2 hours. Perform oral care at least every 4 hours.
Yeah, so okay. So then so select all that applies. So again we'll make the column good and bad, positive and negative, right?
Mhm.
So keep the head above 30 degree is positive or negative?
Yes, it's positive.
Positive. Yeah,
Positive.
put in the yes column.
Yes.
Antibiotics to prevent pneumonia.
No.
Prophylactic antibiotics, why not?
Yes. I thought about coronavirus. Antibiotics are not good. Okay. Yes.
For pneumonia is bacterial, not corona. It doesn't say specifically viral pneumonia.
Okay.
It is to be bacterial pneumonia.
Perfect.
Yeah, restrict fluid, is this good or bad?
This one is bad because
Bad. You have to give fluid so that there is liquefaction of all this phlegm, right? So we have to give more fluids, not less. So this is bad. Okay. Reposition patient every 2 hours.
yes, this one yes.
Yes. And perform oral care every 4 hours.
It's not
Yes.
important.
Oral care we just told now, no?
Yes.
Last question.
So
Ventilator associated pneumonia.
so we must clean the ventilator every 2 hours, but not 4 hours.
No,
Not.
every four. Wait, let me see if maybe I made a mistake. Okay, let's see the answer. Okay.
Mhm.
Yeah. So keep the head of the bed. Yes. Reposition and perform oral care to prevent hospital associated pneumonia. Nurse should provide oral care is not 2 hours. Reposition is every 2 hours. Oral care is every 4 hours.
Mhm.
I
And
take that back. It's my mistake. Okay.
okay,
It is oral care every 4 hours and reposition every 2 hours.
perfect. Okay. Mhm.
And keep the head of the bed to okay. So you don't have to use antibiotics unless there is diagnosed pneumonia. Just to prevent pneumonia, no need for giving
Mhm.
antibiotics. If they diagnose, then you give. Okay, good job. Okay, next one.
Mhm. A nurse is caring for an intubated patient on a mechanical ventilator. The patient is in need of an endotracheal suction. The nurse expects to find which of the following. So the nurse Uh,
You have to pay attention that it select all that apply. So you
uh-huh.
say that, don't forget. Yeah.
Yes, more answers. Uh, intubated patient with the ventilator. The patient is in need of endotracheal suction. The nurse expects to find which of the following. What must to search the nurse? Um, uh, 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 mm, Making the endotracheal suction.
Mhm.
Why we need the endotracheal suction? Uh, okay. Uh, Coarse bronchi.
Course wrong guy. Mm-hmm.
Coarse bronchi. Um,
Mm-hmm.
okay. A high peak inspiratory pressure. Increased oxygen requirements. Clear breath sounds. Pulse of 62. Low peak inspiratory pressure.
Mm-hmm.
Uh,
So, so Bogdan, have you seen any patient on mechanical ventilator during your clinical time?
yes.
Yes. Have you seen anyone doing suctioning for the patient when they are on the ventilator?
Uh, no. This one, no.
No. Okay. So sometimes when the patient is on the ventilator, we have to suction whenever there is needed, right?
Mm-hmm.
So when do we suction? When we have auscultate the lungs, if the patient has coarse bronchi, means when you are listening, there is you feel that the tube is full of secretion, like this kind of sound.
Mm-hmm. Mm-hmm.
Then you know, oh, the tube is having too much secretion, so you have to suction.
Perfect.
Okay, so
Mm-hmm.
one is that. Next is when there is high inspiratory pressure, means there's too much, either the tube is kinked or the tube is blocked, then the ventilator will alarm high peak inspiratory pressure, because there is some blockage in the tube, and the ventilator has to go against this to push it harder, so it will alarm. So then you know, oh, something is going on. I need to check the tube.
Mm-hmm.
Either there is a kink in the tube, it's blocked, or there is secretion that I have to suction out. Okay.
Yes.
Also, the other time is increase oxygen requirement. How will you know increase oxygen requirement? You are keeping the patient on 40. Say if the patient was stable for 40% oxygen. Suddenly, the patient SpO2 is going down. You didn't change anything, but the saturation is going down. Then you think, oh, what is going on? Maybe there is some secretion. Let me suction and see. So when they have increased oxygen, you have to suction. If you have
Okay.
clear breath sound, do you have to suction? It's
Uh,
clean and clear.
uh, no, I don't remember this.
No, you don't have to. When everything is clean and clear and there's no change in no high inspiratory alarm, there is no bronchi, nothing, and oxygen saturation with for whatever setting you set on the ventilator, saturation is above 95. No need to do anything. So no need. So
Yes.
it does not need
Negative.
to suction. Pulse of 62 is very good. The
It's good.
patient is stable. Between 60 and 100 is optimum. So no need to do anything. Just leave him alone,
Mm-hmm.
right?
Yes.
Low peak inspiratory pressure. When we have low inspiratory pressure, when somewhere there is leak, when
Mm-hmm.
the tube is disconnected or something, then we have low. Then what we do, we don't suction. We have to check the whole tube. Maybe there's a hole in the tube or something somewhere got disconnected. Then there is low. So suctioning you need to do only when you have
Uh,
this, or this.
yes. Three. Uh,
Okay? Is that
yes.
clear?
Yes.
Situation is clear?
Yes. Yes. Yes.
Okay.
Mm-hmm.
So, suctioning is indicated for the presence of wet respiration. With wet respiration means like the
Mm-hmm.
that kind of sounds.
Presence of the liquid.
Mm, yes. Then increased peak pressure, bubbling in the ET tube. Bubbling means there is you can see it even. Like there's so much secretion and bubbling inside the ET tube from the mouth. If you look,
Mm-hmm.
there's that. Then patient will become restless when they have this. They can't when the air is not going properly. They start becoming restless,
Mm-hmm.
agitated.
Mm-hmm.
and then increase inspiratory rate and heart rate can go up, and they can become even tachypnic, and SpO2 will go down.
Mhm.
When all this is happening, that means you know your patient on the ventilator, something is going wrong. It's not okay. All right. So the
Okay.
first thing as a nurse you will do is try to suction, and then if suctioning doesn't work, then you have to call the respiratory therapist, and you have to call your doctor, and you have to do an ABG. Maybe the tube got dislodged or something else is happening. But the first thing you will do is check for auscultate the lungs and suction the patient.
Okay.
Okay. Okay. Next one.
The nurse is caring for a post-operative patient at risk for pneumonia. What interventions can be implemented to reduce the risk of pneumonia? Uh, Select more answers. Frequent repositioning. Uh,
So in so you rephrase and understood what what it is asking you.
yes,
Okay.
yes, yes.
Okay.
Uh, what can help to prevent the pneumonia?
Mm-hmm.
Frequent repositioning. Yes.
Mm-hmm.
Incentive spirometer. So using the spirometer for what? For understand if the lungs contain a lot of oxygen, a normal.
No. Incentive spirometer is the one that you give to patients and you tell them to suck inside and that ball goes
Yeah.
up. Have you seen that?
Yes, yes, yes.
That one. That one. We give it to all the post-operative patients because when they have general anesthesia, everything is like paralyzed,
Mhm.
right? When you give the medicine for general anesthesia during operations, then the lungs will also be paralyzed. Then
Exactly.
the lungs will be pooling the fluids, and some of the lung alveoli will be stuck to each other. So when they become awake after surgery, when they are awake and they come back to consciousness, we will tell them, okay, take this incentive spirometer and you have to suck, and you raise this ball up every hour 10 times. So we
Mm.
say when you're awake, when you see the TV, if the TV is on, this is how we say. Whenever there's commercial coming on the TV, suck this 10 times. So when they do this, what happens? They open like this. When they suck, the alveoli all open
Mhm.
up, and so when it opens up, then there's something called as hypostatic pneumonia, which means because the lung was not in use for some time, the lung can go into pneumonia. Means all the liquid sitting there can cause pneumonia. So to prevent that, we have to give them incentive spirometer. Okay,
Okay.
so
So
it is
it's good. It's good. Yes.
good. Yes.
Incentives parameter.
Mm.
Uh, Coughing. Yes.
Yes, coughing is good. You have to make them cough and deep breathe.
Coughing. Yes. Bed rest. Uh, no, it's better to move the body.
Yes, yes.
Early ambulation. Uh, so more quickly, we must to ambulate the person more quickly.
Yes,
Yes. No, we
yes.
must be ready
This,
to
yeah.
help.
This is
Uh,
the opposite of bed rest, right?
yes.
Bed rest is bad. Early ambulation is good.
Mhm. Limiting fluids. No. Uh,
No. Okay, let's see. Yeah, frequent reposition, incentive spirometer, coughing, and early ambulation.
mhm. To prevent the development of pneumonia, the patient should cough, deep breathe, reposition frequently, and ambulate early. Use the incentive spirometer and take medication for pain. Bed rest and limiting fluids will increase the risk of pneumonia.
Yeah.
Perfect.
Okay. Next.
The patient is diagnosed with a right tension pneumothorax. The nurse would understand that the pneumothorax is worsening when which of the following is observed. Select more answers. Uh, uh, so, tension,
So
pneumo.
you know what pneumothorax is?
Uh, I remember something, but there is it's the problem with the lungs, with the respiration and tension. The person can't breathe good.
Yes, tension pneumothorax is like you know the inside the lung there is a hole, the pleura there is a hole. So because there's a hole, air what we are breathing it goes between the two pleura. Okay, there's one external pleura, internal pleura, right?
Mhm.
So because there's a hole in the because of some accident, something happens on the road, maybe a road traffic accident or something. There's a there will be a hole in the lung, and that hole when they take deep breath, the air from outside and the air from inside both will go into the lung, and it collects between these two layers of the pleura, and then there is this will with each breath this is going to go more and more, and then what happens to the lung? There's no place for the lung to inflate.
Mm-hmm.
The lung space is very little, so when there's no lung space, then the patient will not get any breathing, right?
Yes.
No air to move in the circulation, so they will become
Asphyxia.
severely they will become breathless, and they can die from this, because the whole lung can push the whole mediastinum means the aorta, the heart, everything that's sitting in the middle.
Mm-hmm.
This lung can push this whole thing to one side, and they can die.
Yes. For the
So
asphyxia.
yeah, so this is a very dangerous condition, and if we see a patient in this, immediately we have to put the chest tube to remove the air. If we are in on the road and there is no chest tube, then what do? We take a needle and we put with a glove, like we cut a glove, finger of a glove, put a sterile needle through that sterile glove, and clean the skin and just put it into the top of the lung, so the air will escape from this needle out,
Mm-hmm.
and no air will come inside because the glove will collapse when the patient is breathing inside. So we can, but that is only temporary fix till you take the patient to the hospital. Once the patient reaches the hospital, we have to put the chest tube so that the patient's can expand. Otherwise, they will die.
Mm-hmm.
Okay?
Yes. So,
Yeah.
answers. Displacement of point of maximal impulse. Tachypnea. Left deviation of the trachea. Bradycardia. Right deviation of the trachea. Uh, Increased oxygen requirements. Bilateral uh, crackles.
Mhm.
Uh, uh,
Yeah. So what are the worsening? So the nurse knows that this patient is having right tension pneumothorax.
mhm.
So she will understand that it's getting worse when she observes what things. Displacement of point of maximum impulse. Do you know what is point of maximum impulse?
uh, yeah, it's the time during which the air is more intense inside the lungs.
No, actually, the point of maximum impulse is where you hear the heart rate the best. If you put your stethoscope
Mm-hmm.
and you listen to the heart rate, where you are hearing the heart rate, that is a point of maximum impulse. Like it is in the, so if that moves to the more to the left side, so right tension pneumothorax means everything is being pushed on the right to the left. So if this moves to the left, so the heart rate, instead of getting like you are supposed to listen to the heart rate when you put your stethoscope between the third and the fourth intercostal space, right? If you put along the clavicle, mid clavicular line, that should be your point of maximum impulse where you hear the heart rate. If it gets displaced into more left side, maybe near the axilla or something, definitely that was not the where you heard the heart rate the best before. That which means it's getting worse. You understand what I'm trying to say?
Yes, yes.
Yeah.
So,
Okay. And then tachypnea.
tachypnea. Yes,
Mhm. Yes. Left deviation of the trachea means left deviation means moving the
to the
trachea. Trachea should be in the middle, but you see trachea has gone to the left.
to the left.
Means, mm,
Yes,
yes, so that's a problem, right?
yes, exactly.
Bradycardia.
Bradycardia. No.
Yes, it could be because the
Ah,
heart is also going on that side. Heart cannot pump properly now. So
yes.
it could be that the patient is getting worse now.
The lung is present on the heart.
Hmm.
Okay. Right deviation of the trachea. No.
No, because it's right tension pneumothorax, it should push it to the left, not to the right.
Yes. Increased oxygen requirements. Yes.
Yes.
Bilateral granules. Uh,
Mm. No.
no. No.
Crackles is usually in pulmonary edema. Here we don't have any fluid. What we have is air. So you will not, and that air is also outside of the lung. So crackles, most probably, you will not hear any crackles. Okay, let's go to the answers.
Mhm.
Okay, read.
Displacement. Displacement of point of maximal impulse. Uh, Tachypnea. Left deviation of the trachea, increased oxygen requirements. Attention pneumothorax occurs when there is a trauma, like a stab wound, creating on one-way valve effect that allows air to enter the pleural space but not escape it. It gradually worsens as air leaks in and can often be confirmed by X-ray when a deviation of the trachea to the unaffected side is noted from the build-up of pressure on the affected side. Uh, Tracheal deviation to the unaffected side is characteristic of worsening tension pneumothorax.
Mhm.
Other signs would include asymmetry of thorax and breath sounds, worsening cyanosis, tachypnea, and displacement of the point of maximal pulse. O-
Mhm.
Oxygen uh, demands increase as there is a less functional pulmonary capillary bed for diffusion. Bradycardia and crackles are not symptoms of pneumothorax. So bradycardia and
Yeah.
crackles. Okay.
Yeah. So now that's it's clear now to you, right?
Yes, yes, yes.
Okay. Next question.
A nurse is caring for a client who underwent thoracic surgery. Which of the following should the nurse assess for manifestations of tension pneumothorax?
Mhm.
Select all applicable. Uh, Monitor. Okay. The nurse is caring for a client who underwent. Uh, so the patient had the thoracic surgery. Uh,
Yes.
uh, so what must check the nurse uh, for understand if the person has the tension pneumothorax?
Correct. So the patient can like even so one situation where I told you that a person can have pneumothorax, tension pneumothorax during road traffic accident, right?
Yes.
The patient can go into pneumothorax even other in other circumstances. One is like after thoracic surgery, normally they come with the chest tube, right?
Yes.
Sometimes the chest tube, when we are trying to reposition the patient or something, if the chest tube gets displaced and pokes the lung and then ruptures the pleura, you can have tension pneumothorax. Also, you can have tension pneumothorax when a patient is on ventilator and you put too much pressure. The pressure in the machine is too much, and
Mm-hmm.
what it did is it blew up some like balloon. No, this
Yes.
alveoli are like balloons. It breaks the balloon. So
Mm-hmm.
it's called as barotrauma. Trauma because of pressure. Baro means pressure.
Pressure.
So barotrauma means because of high pressure in the mechanical ventilation, the patient went into spontaneous pneumothorax. So these are other situations where you can have pneumothorax. Now in this question, your patient has underwent a thoracic surgery, and after that we always have to keep watching whether we have any features of or signs and symptoms of tension pneumothorax. So the question is asking you what you will assess.
Mm-hmm. Mm-hmm. Monitor blood pressure, heart rate, and respiration. Uh, yes. This one,
Yes,
yes.
because any change, if it is if the blood pressure is getting high, the heart rate is getting high, and the respiration is getting high, that means the patient is hemodynamically unstable.
Mm-hmm.
And when there is any hemodynamic instability, there's something wrong going on. So that is basic. So anytime any problem happens with your patient in any situation, the first thing you want to do is check the vital signs.
Yes. Mhm.
Okay.
SS for lateral or medial PMI shift.
Yeah.
Uh,
Is that correct or wrong?
yes, it's
Yes,
correct.
because in the last question, remember I told you, because of this pushing, the heart will move also, either to the left or right.
Mm-hmm.
It will move. So the where you're hearing the point of maximum impulse, which is the best heard heart rate point, that will move either left or right. Correct.
Mm-hmm.
Next.
Auscultate breath sounds for crackles. No, crackles are absent.
Okay. Good.
A check for tracheal deviation to an affected site. Um,
Yes or no?
uh, yes, yes.
Yes. Yes.
Monitor for progressive cyanosis. Yes. Extreme rattleness,
Restlessness.
restlessness, agitation, and severe dyspnea. Yes.
Yes.
Cyanosis.
Yeah.
Mm.
Hmm.
A monitor for fever, hemoptysis, uh,
Hemoptysis means
hemoptysis.
coughing up blood.
Mhm, mhm. And signs of right-sided heart failure, right side, and we have what side affected? Uh,
No, this is right-sided heart failure.
mhm.
Okay, so will the patient have fever, hemoptysis, or right-sided heart failure?
No.
No. These are features like fever, hemoptysis, and right-sided heart failure. For pulmonary embolism, this could be true,
Yes.
not for pneumothorax. Okay.
Pneumothorax. Yes.
Okay. So which are your answers? Number one, number
One,
two,
two.
number
Number
four,
four,
and number five.
five, two.
Yeah, okay. So number monitor heart rate,
Uh,
assess for PMI shift, check for
rest.
deviation of the trachea, and then monitor for cyanosis. Correct. Okay.
Mhm.
So this is clear, right? You want to read this whole thing, or you're
Yes.
okay?
I would like. I would like to read.
Okay, read.
Attention pneumothorax usually results from trauma, such as a stab wound, and develops when air is trapped in the pleural space during inspiration and cannot escape during expiration. The intrapleural pressure becomes greater than the lung tissue pressure, resulting compression of the lung and surrounding structures. The clinical manifestations include point of maximum impulse shift, a tracheal deviation toward the unaffected side, uh, progressive cyanosis, restlessness, anxiety, dyspnea, um, sudden sharp pain on the affected side with chest movement, breathing, or coughing, asymmetrical chest expansion, and diminished or absent breath sounds on the affected side. Evidence of labored breathing and hemodynamic compromise, uh, tachycardia, hypotension suggest a possible tension pneumothorax. Crackles are a manifestation of acute pulmonary edema seen with circulatory overload resulting from delayed re-expansion of the affected lung after surgical treatment. So,
Okay, that's clear.
yes, so the crackles,
Practice always is for pulmonary edema.
edema,
Okay.
yes, yes, yes,
Yeah, pulmonary edema.
not for the pneumothorax.
No.
Good.
Okay. Okay.
Uh,
Next question.
the nurse is caring for a patient diagnosed with pleurisy. Which of the following assessment findings is a characteristic of pleurisy or pleurisy?
Pleurisy.
Pleurisy.
Mhm.
Pl-
Yeah. What is pleurisy?
I would like to refresh it to.
Okay. Look up on your phone. Google.
Yes, yes. Pleu- uh, Pleurisy. Inflammation of pleura. Uh,
Mm.
um, thin layer of tissue that lines the lungs. Okay, inflammation of the pleura.
So instead
Pleurisy.
of saying pleuritis, we call it pleurisy. Normally,
Pleu-
when there's inflammation of the anything, whatever we say itis, right?
yes,
Like
yes, yes.
nephritis, pericarditis. So instead of saying pleuritis, we call it pleurisy because
Pleurisy.
of the yeah, because of the condition. The condition is called pleurisy because the patient comes with chest pain, which is different from the chest pain caused by heart problem. Heart problem, chest pain is like the way they describe is not with breath. The pain is there in spite of whether you breathe deep or not breathe deep. It's there. It doesn't change with breath. But in pleurisy, the chest pain will be changing with the breath. That's the difference between pleurisy and the chest pain angina. Angina is the chest pain for the
Yes.
heart, right? Decreased blood supply to the heart muscle because of either coronary artery disease or coronary spasm or something like that. That angina does not have anything to do with breathing, the chest pain for angina. But the chest pain for pleurisy usually is something that will intensify or become more with breathing in.
Mm-hmm.
That's
So,
how you differentiate, okay? But then again, you have to put your stethoscope and then you have to auscultate also.
mm-hmm. Okay. So, what can be
This is a select all that apply, by the way.
use of accessory muscles?
Mhm.
Uh, yes.
Okay,
The
what is the meaning of use of accessory muscles?
uh, I don't know, the muscles of the abdomen.
Okay, muscles of the abdomen. Then
Abdomen.
what else?
Also of the shadows of the hands.
Hands,
The muscles of the chest.
intercostal retractions
Uh,
is what you're meaning.
yes.
Like not regular breathing. When you're regularly breathing, you're not having retraction of the intercostal muscles. Intercostal muscles are the muscles between the ribs, right? Number one,
Yes.
number two, we have like 12 ribs, right? Thoracic rib cage. When in between that muscle also there's retraction, then it is accessory muscles. Then nose, the nasal folds will be opening and closing. Then that is accessory. So using accessory muscles, when do they do that? When they are in severe
It's
respiratory distress,
mhm.
right? When
Yes.
someone is trying to breathe hard, that's the time that you use your accessory muscles for breathing.
Okay.
Hmm.
Strider.
So will they?
So
So accuracy, will they have accessory muscle breathing?
no.
No. If they breathe so hard, it'll pain too much, so they will try not to breathe so hard, I guess.
Yes.
Okay.
Mm.
Strider. What is strider?
I will check it too. So,
Strider is like snoring. Snoring is when you sleep. Strider is the sound that you hear when someone breathes when they are awake.
uh,
Like that. You can hear someone's breathing like that. Can you hear me?
yes.
Yeah. So that if without stethoscope, without anything, you're standing next to them and you're hearing them breathe like this, that's called strider.
Strider. Okay. Strider. Yes, it can be a
Okay. Next
strider.
one.
Tachypnea with rest. Tachypnea. Yes. So the person can try to breathe more quickly to take more oxygen and to rest for don't have the pain.
Okay.
Uh,
Next one.
Dull pain that intensifies with expiration. Dull pain. Dull. Mm. Uh, okay. Yes, can be dull pain with expiration. So the person is expirating and the pleura is moving. The person has the pain. Sharp pain. Sharp pain that intensifies with inspiration. Also, uh, the pain is present every time when the person is inspirating and expirating. Uh,
Okay.
Pleural friction rub. Uh, Also, it can be
How do you live? How do you know if you are having pleural friction rub?
pleural friction
How
rub.
do you find out? What do you do to find out?
Mm. We must to ask for the person to inspirate more strongly and
No, you have to listen to. You have to auscultate,
mhm,
and you when you hear a rub, the pleural. Remember, I told you the pleural cap, the layer of the pleura, the external, internal. These two rub because there is less surfactant. You know between the two layers of the pleura, there is
the
some
liquid.
liquid that is making it to smoothly glide so that when there is inspiration and expiration, there is smoothly it will move. So when the surfactant is not enough, there will be rubbing. This will rub against each
Mhm.
other. And that rubbing is the one that causes, because of the inflammation, it's thicker and it is rubbing, and so it causes severe pain
Mhm. So,
when they breathe. So
pleural
you can
friction
hear
rate.
it only when you put your stethoscope
Mm-hmm.
and auscultate it, then you can hear that. Okay, so let's go to the answers. Okay,
Mm-hmm.
okay.
Okay. A sharp pain that intensifies with the inspiration.
Inspiration and pleural friction. So let me go back. Oh, no, go back. So use of accessory muscle when pleurisy is there, they don't have, because they try not to breathe too hard.
Mm-hmm.
It's paining them, so they will not use. They are trying to not breathe very using the accessory muscles. There is no stridor because there is no blockage in the airway.
Mm-hmm.
Stridor happens when there is blockage in the airway. There's something, some tumor is there, or there's some secretion or something. Then you have stridor. Okay, so they don't have tachypnea with rest. No, when they're having rest, they don't have tachypnea. Tachypnea with rest should be in pulmonary embolism or some other condition. Okay,
Mm-hmm.
so that is also not there. Dull pain which intensifies with expiration. No, it's normally sharp pain. Pleurisy always they have sharp pain,
Sharp pain.
and that is when they breathe in,
Mm-hmm.
inspiration. When they have inspiration, when they inspire in, that's when they have. So
The
these
pain.
two are the answers, not these.
Okay.
Okay, so read the explanation.
Explanation. Pleurisy often causes a sharp uh, uh, knife-like a pain
Knife
that.
like pain. Knife like pain means as if someone is cutting. So it's
Yeah.
very sharp and very painful,
Mm-hmm.
intense pain. Okay, knife like pain
Mm-hmm. And this is
that will get worse when they are breathing in.
yes. The term pleurisy actually refers to inflammation of the pleural. This pain is due to friction between the pleural surfaces and can be hard on auscultation as a pleural friction rub. The other answer choices are not characteristics of pleurisy, but can occur with many respiratory disease.
Yeah, is that clear now?
Yes, yes, yes.
Okay, next one.
A client who underwent pneumonectomy,
Pneumonectomy. Pneumonectomy.
pneumonectomy has the nursing diagnosis of ineffective airway clearance related to increased secretions and decreased coughing effectiveness due to pain. Which of the following interventions can help the client achieve effective airway clearance? So, pneumo, pneumonectomy,
Pneumonectomy. So what is pneumonectomy?
uh, ectomy, it's the cutted part of lung.
Yes. So the person, the client had a pneumonectomy, which is part of the lung has been removed.
Removed.
Right? They didn't say whether it's only one lobe or one segment or the whole lung. They have not mentioned that, but they said that patient had pneumonectomy, and now the patient is having difficulty in clearing the airway. Right?
Mhm,
So what will help to achieve this clear airway?
mhm. Uh, scat.
Select all that apply. Select all that apply. Right?
Uh-huh.
So more than one answer.
Yes. Schedule coughing and deep breathing sessions at time when pain medication is maximally effective. Uh,
Is good or bad?
uh, mm, okay. No, it's
Not good?
not good.
Why?
Uh, the person has this problem, and there is the trump the clothes of the blood, so it's better to not mm, coffin maybe.
No, what are you saying? I didn't understand anything.
Mhm.
Say again.
Uh, mm,
This is a patient who underwent pneumonectomy. Okay.
yes, yes.
Now he is having difficulty clearing his airway.
So it's better that
Because
he
of
will
increased
coffin.
secretions and decreased coughing. Their decreased coughing is because of pain. He is not coughing enough, and so he's not clearing his secretions. So you give him medication, and when the medication is maximally effective, when he's complaining of least pain, you ask him to cough and take deep breaths.
Mhm.
Is
It
that good or bad?
Yes, it's good. It will help him to clean the airways.
Yeah. So put it in the good column.
Yes. Place in complete lateral position after pneumoectomy. Uh,
Good or bad? Complete
yes,
lateral position.
yes, it's good.
Is good? Okay.
Or in sitting position. Mm. Avoid traction on chest tubes while changing client position. Uh, Avoid traction on chest tubes. Uh,
Will that help with the clearing the airway, avoiding traction on chest tube? See, always after lung surgery, patient will have chest tube. That you know, right?
yes.
Yeah. So avoiding traction. Traction means pulling. Avoiding pulling on the chest tube while changing the client's position is a good thing. But does it help with airway clearance?
So it's not important.
Does it help?
Bad.
Important. So
Yes.
put in the bad column.
Place the client on semi or high Fowler's position once the vital signs are stable. Yes.
Yes. Okay.
Uh,
So what is the previous? Place the patient in complete lateral position after pneumonectomy. Should be put in complete lateral position?
no, high Fowler's position is not lateral position.
No, you after immediately after pneumonectomy, you will be putting the patient on with the operate side up. So the side that is not operated, that will be down, and that operated side will be up. You will put them like that, but with head little bit raised up.
Okay. So place in complete lateral position is not good for this reason. Yes. Okay. High Fowler's position. Offer sips of water frequently um, uh, for clear the mouth. Uh, yes, yes. In
Will
this,
that help to prevent clear airway?
uh, no, no.
No.
It will help to um, uh, make the mucus more liquid and to
Yeah,
exit.
so it will help. It's good, no?
Yes, it's good.
Mm.
Uh, Help the client cough and deep breathe every 1 or 2 hours while awake during the first 24 to 48 postoperative hours. Uh,
Will
Help
that help?
to cough.
Uh,
Yes,
yes. Okay.
for
So
clean
which are your answers?
the last one, the water
Mm.
and the high Fowler's position.
And what about number one?
Uh, Schedule a coffin. Yes, also that one. Uh, the first one.
Let's see the answers, okay?
Yes, yes,
Yeah.
yes.
So the first one is correct. Schedule coughing and deep breathing sessions at times when pain medication is minimally effective. Then second one is place client on semi, when vital signs are stable, you can put them on high Fowler's position. But till the vital signs are stable, like immediate post-operative, you should put them on lateral side with head of the bed little up if they're conscious. Then
Mm-hmm.
give water as you said, and then also cough and deep breathe every 1 to 2 hours.
Mm-hmm.
Okay, you
Okay.
can read the explanation and try to understand that. Read it.
Yes. Patients should be placed upright to help lung um, expansion and lung expansion and facilitate ventilation with minimal effort. Increasing the volume of air in the lungs promotes expulsion of secretions. Schedule coughing and deep breathing sessions at time when pain medication is maximally effective. This should be scheduled every 1 2 hours while the patient is awake in the first 2 days
Mm-hmm.
post-operative. uh,
Mm-hmm.
Offering frequent sips of water helps to address airways clearance by encouraging hydration, which keeps secretions thinner and makes coughing more effective.
Mm-hmm.
Lateral positioning should be avoided due the risk of compression remaining lung because the mediastinum is no longer held uh, in place on both sides by lung tissue.
Mm-hmm.
Closed chest.
Understand? You understand that?
Yes, one
Yes. So
one.
you have to put the person just after post-operative position. You should put with the operation side up
Up.
and the
Yes,
other side. So then what will happen? The remaining lung, if they did a lobe removal, the other lung will expand and fill up the empty space,
it
and
will.
then the mediastinum will be correctly sitting in its position. Because lung tissue is a very elastic tissue, right?
Mm-hmm. Yes,
So
yes, yes.
it should open and fill up the place.
And it will rest on the
Yeah.
little one. Closed chest drainage is not used after pneumonectomy because there is no lung to re-expand.
Oh, okay. So they don't use a chest tube after pneumonectomy.
Yes, because there is no space for it.
Okay. Okay. Next one.
Mhm.
So after this question, you want to take a little break. You can take like 10 minutes break,
Oh, okay.
10 or 15 minutes. You want to have dinner and come. Then we will start after maybe 8:15.
All right. All right.
Okay.
A nurse is caring for a patient suspected of having acute respiratory distress syndrome. Which of the following assessment data would support the suspected diagnosis? Ask a patient suspected having acute respiratory distress syndrome. It's in the brain. It's correlated with the brain.
What acute respiratory distress syndrome?
Distress. Distress.
What?
No.
No, nothing to do with the brain.
Oh,
It's the lung. The problem of the lung.
oh, okay.
Mhm.
Distress. No.
Well, you're thinking of some other word. I don't know what word are you thinking about. But this is ARDS. ARDS is acute respiratory distress syndrome or
Okay.
adult respiratory distress syndrome.
All right. Which uh, so what we must which symptoms will be good for the distress uh, syndrome for the acute respiratory
Sudden breathing difficulty is what we say we call by acute respiratory distress syndrome is the cause could be anything. It could be COPD, it could be asthma, it could be pneumonia, it could be anything. But what happens is suddenly the patient is not able to breathe properly and requires like intent, like maybe needs a BiPAP or a ventilator or something. You know, they
Mm-hmm.
so that is what. So now they're asking you what following assess as in when you do assessment for this patient with acute respiratory distress syndrome,
Mm-hmm.
what you are what you're expecting to see.
Mm-hmm. Okay. Decreased breath sounds. Yes. Confusion. Confusion if the oxygen is absent. Yes. Can be. Yes. Slow onset. Uh, I don't know.
Is it slow? Acute respiratory. The word acute means slow.
No, no. So
No,
it's not
opposite. Acute
opposite.
means fast and sudden.
Fast. Mm-hmm.
Chronic means slow and gradual.
Mm.
So acute means fast. So slow
Fast.
onset is not acute.
Mm-hmm. Yes.
So it's a wrong one. So put it in the negative answer list.
Mm-hmm. Hypoxemia. Hypoxemia, despite a high FiO2.
Yeah. So FiO2 is fractional inspiratory rate of oxygen. The same as your percentage of oxygen that you give. So when you are using a ventilator or a BiPAP, we don't call it liters per minute. Normally we call the FiO2. Okay. So you are giving 100% FiO2 and still the patient is having less saturation, hypoxemia. In the blood, the oxygen level is still low. Is this characteristic of acute respiratory distress syndrome?
Low? No.
Yes,
Oh, yeah.
yes. The saturation is low. You are giving a lot because the patient is in distress. You're giving oxygen, but still the patient's saturation is not coming up. The patient's saturation is low. So this is hypoxemia, low
Hypo.
oxygen,
Hypo.
hypooxemia. Hypo means low,
Low
oxy means
oxygen.
oxygen, and mia means in the blood. So low oxygen in the blood, even though you are giving high FiO2, high amount of oxygen you are giving,
Mm-hmm.
still it is low. That is
Yes,
very characteristic of ARDS.
I understand. So, yes, this one positive. Tachypnea. Yes.
Yes, somebody who's struggling like this to breathe, they will definitely be trying to breathe hard. So they will have breathe fast and hard. So it will be tachypnea. And then
Yes. Crackles. Absent. Absent.
practice may or may not be there, we don't know, depending on the cause.
Mm-hmm.
If the cause is because of pulmonary edema or like CHF or something, maybe there is crackles. If not, maybe not.
Mm-hmm.
Yeah.
Yes.
So let's see what are the answers. So decreased breath sounds.
Mm-hmm.
Oh, crackles. So hold on. Let's go back to.
Just for understand.
Okay. So nurse caring for a patient suspected of having acute respiratory distress. Which of the following assessment data would support the suspected? Okay. So it says crackles. Okay. So decreased breath sounds. ARDS is a condition of diffuse alveolar injury that prevents diffusion of oxygen into the bloodstream. So the breath sound will be low.
Mm-hmm.
The lower level of patient's arterial oxygen level with high FiO2, the worse the patient can. This was pulmonary edema and because they have pulmonary edema and decreased surfactant production increases the thickness of the alveolar capillary space, increasing this distant oxygen must travel to reach the blood. The result in hypoxemia and acidosis.
Acidosis.
Crackles on auscultation can occur secondary to pulmonary edema. Confusion,
Secondary.
confusion can occur after the onset of hypercapnia, and that means later on, not immediately, but later on, they can have confusion also.
Mm-hmm.
The tachypnea is often a symptom of ARDS. Decreased breath sounds may also be noted depending on the degree of pulmonary edema. ARDS is an acute syndrome with rapid onset. You would not expect slow onset with ARDS. So actually everything except the slow onset. So decreased breath sound is there, confusion will be there, slow onset will not be there. This will be there, this will be there, and this will be there.
Also the crackles, because
Yes, because one of the things for
yeah,
acute respiratory distress, what happens is pulmonary edema. So they
edema.
will have crackles.
Perfect. Acute respiratory distress,
Okay, so
edema.
now you can go for break, and
Yes.
then 8:15 maybe we can come back.
Okay. Okay. All right.
Oh,
8:15.